Kia ora everyone, and welcome to our Goodfellow webinar this evening. Tonight we're discussing the role of the GP in the care of the child with epilepsy. The Paediatric Epilepsy Health Pathways have recently been released. I'm Dr. Louise Kugler from the Goodfellow Unit, and tonight I have with me Professor Sadleir and Dr. Suzanne Davis, I beg your pardon. Lynette is a physician scientist with an expertise in epilepsy. She's a paediatric epileptologist at Wellington Children's Hospital and the director of the Epilepsy Research Group at Wellington Children's Hospital. Professor Sadleir is the past president of the New Zealand League Against Epilepsy, the chair of the International League Against Epilepsy SNOMED Task Force, and a member of the ILAE Task Force that developed the flagship educational website epilepsydiagnosis.org. Dr. Suzanne Davis is a paediatric neurology with a special interest in epilepsy. She is the president of the New Zealand League Against Epilepsy and the chair of the Ministry of Health Epilepsy Improvement Project, TAG. I'd like to hand over now to Lynette and Suzanne. Kia ora to you both and welcome.
Thank you so much, Louise, and thank you to everybody who is listening online and who's going to listen to this and the recorded version. We're really grateful for you coming to listen to us speak. So we are presenting today on behalf of the New Zealand League Against Epilepsy. And the New Zealand League Against Epilepsy is a non-profit organization consisting of clinicians and basic scientists whose aim is to try and increase the quality of life for children with epilepsy within New Zealand. So before I talk to you about what we're going to be going over today, I thought we could just focus on the problem. So I've been fortunate enough to have a few PhD students recently doing some epidemiological projects. And so we have some real New Zealand data. So Shema's recent paper in neurology in 2021 identified that 3.4 per 1,000 New Zealand children have treated epilepsy, which is approximately 4,500 children throughout the country. And that the prevalence of epilepsy or treated epilepsy is higher in the lower socioeconomic groups. And when you account for the socioeconomic status, their prevalence is less in Maori, Pacific, and Asian children compared to New Zealand European. Gemma Poke, who some of you may know, is also doing a PhD with me. She's a clinical geneticist, and she's looking at the prevalence and the cumulative incidence of the very severe epilepsies. And she's identified that 1 in 340 New Zealand children have epilepsy associated with a degree of developmental impairment before the age of 16. And that of that group, 1 in 600 have a developmental and epileptic encephalopathy. And what we mean by that is that's the group of epilepsies where the seizures or the interictal discharges between seizures impact negatively on the brain and have a negative impact on development above and beyond what you would expect for the underlying pathophysiology. And an additional 1 in 800 have intellectual disability and epilepsy, but in those group of children, the seizures aren't negatively impacting on their development. So epilepsy is a significant problem in New Zealand. And what the New Zealand League Against Epilepsy, why they funded this webinar, is because what we really want is to help general practitioners, yourselves, and the pediatricians and the pediatric neurologists work really well together so that we can all make a difference into the quality of life of children in New Zealand with epilepsy, and hopefully that you're going to feel a little bit more empowered at the end of this. So what we're going to talk about for the next 45 to 50 minutes or so, and then we've got time for questions, is outlined here. So we're going to first of all look at what's been happening over the last 8 years with regard to updates both globally and nationally. And we're going to spend most of the time, however, talking about the community health pathways, which, as Louise mentioned, we have just launched 3 new pediatric epilepsy pathways. And we're going to illustrate some of the concepts and the pathways by the use of 3 cases. So first of all, what's been happening globally? So the ILAE, or the International League Against Epilepsy, has been pretty busy, and starting on in 2014. So what they've been doing is there's a lot of groups of experts who've been reviewing the evidence and the research that's been done over the last few decades, and making sure that the concepts and the way that we identify and the terminology that we use in epilepsy is up to date and fit for practice. And so the first of the, and then they have written several position papers, and the first one came out in 2014, so that's a wee while ago now, and that was the new definition of epilepsy. So I thought that, no, so that was quite a while ago. So hopefully you all have heard about this, but I thought we'd have a little quiz, first of all, and get your brains going to see if you can identify who has epilepsy. So this is 5 different cases, and we just assume that they're all developmentally normal. And unless it says they're all developmentally normal with a normal neuro exam, unless it says in the little vignette. And so first of all, we've got Adam, who's 12, and he's had 2 tonic-clonic seizures from sleep, and his EEG is normal and his MRI is normal. And then we've got Ben, who's 5, and he's had a single tonic-clonic seizure from sleep, and his EEG is normal and his MRI is normal. And then Claire, who's 8, she's also had a single tonic-clonic seizure from sleep, but her EEG shows centrotemporal spikes. And Doris, who's 11, who's had a single tonic-clonic seizure from sleep, but on her EEG was captured an 8-second burst of generalized spike and wave. And then finally, there's Ellen, who's 2 months old and has had a single focal impaired awareness seizure. And you note she's got some depigmented skin lesions, and her EEG's got focal spikes, and MRI shows that she's got some tubers. So the question is, which of these 5 children have a diagnosis of epilepsy? Is it Adam only? Is it Adam and Claire? Is it Adam, Claire, and Ellen? Adam, Claire, Doris, and Ellen? Adam and Doris and Ellen, or do all of them have epilepsy? So I'll just give you a few seconds just to have a think about those 5 cases. So maybe if you have a pen or something, write it down so that you commit. It's always good to commit to what you're thinking. Which of those individuals do you think has epilepsy, and why, based on what definition? Okay, so as I said, you're not getting a lot of time to think about it. All right, so the answer is, it's Adam, Claire, Doris, and Ellen. Okay, so if you got all those right, well done. You obviously understand the definition of epilepsy. And if you're wondering, we're going to go through them. So the first and the old definition of epilepsy is the first part of the new definition, and what's always been in the definition is that you have to have at least 2 unprovoked seizures which are greater than 24 hours apart. And so both Adam and Doris have that. So Adam is 12 and he's had 2 tonic-clonic seizures from sleep, and it's pretty much irrelevant what his EEG shows and his MRI shows. He's had 2 seizures greater than 24 hours apart, so he has epilepsy. Doris is 11. She's only had a single tonic-clonic seizure from sleep, but her EEG shows 8-second bursts of generalized spike and wave. That's effectively an absence seizure, whether they do response testing or not. If you have generalized spike and wave that goes on that long, so she'll be having absence seizures that she's just not aware of. So she's had more than 1 seizure, so she has epilepsy. And then the second part of this new definition is a single unprovoked or reflex seizure and a probability of further seizures similar to the general recurrence risk at least 60% after 2 unprovoked seizures occurring over the next 10 years. It's very wordy, but and Ellen has epilepsy based on that definition. So she's 2 months. She's had a single focal impaired awareness seizure. She's got depigmented skin lesions. Her EEG shows focal spikes. Her MRI has got tubers. You might recognize that, that looks like that, well, that she's got tuberous sclerosis, but it doesn't actually matter about the depigmented skin lesions. The fact is she's had a single seizure. She's also got epileptiform discharges on her EEG and a structural lesion on her MRI. So even though she's just had a 1 seizure, she has got a greater than 60% chance she's going to have another one. So she doesn't have to have another one. She has epilepsy by the definition. And then the final new part of the definition is if you have a diagnosis of an epilepsy syndrome. And so that's Claire. So she's only had a single tonic-clonic seizure from sleep, but she's got an EEG which shows central temporal spikes. And so she has the epilepsy syndrome of self-limited epilepsy with centrotemporal spikes. And the acronym for that is SELECTS. Now that is one of the new terminologies that's just come into play, and I'll talk a little bit about that later. But the old terminology for this type of epilepsy was epilepsy of childhood with centrotemporal spikes or Rolandic epilepsy. So Adam, Claire, Doris, and Ellen, and each demonstrating one of the parts of the new ILAE 2014 criteria for diagnosing epilepsy. Okay, so in 2015, the next position paper that came out was the definition and classification of status epilepticus. And there's a lot in there, but the most important take-home message from your perspective as general practitioners is status epilepticus now has 2 time points, T1 and T2, whereas previously it was just 30 minutes. And the other thing is that it's different T1 and T2 depending on the types of seizures. So if we look at bilateral tonic-clonic seizures, and T1 is basically the time where you would expect the seizure would stop, but if it goes further than that, they're likely to have it's likely to continue going on for a long time. And T2 is when it's starting to have a negative impact on the brain. So the brain's starting, the cortical cells are starting to decompensate. So for a bilateral tonic-clonic seizure, T1 is 5 minutes and T2 is 30 minutes. But the focal impaired awareness seizures or focal seizures, the T1 is 10 minutes and T2 is 60 minutes. And for absence is 15 minutes for T1. And we don't know how long it takes before you can probably have absences for a very long time before it impacts negatively on your brain. 2017 was a really important year. A lot of some important position papers came out. The first was the classification of seizure types. And I think the most important thing for you to realize if you're not haven't come across this is that it's all about the onset. And so we've got focal onset and generalized onset seizures. And a focal onset seizure means it starts within a unilateral hemispheric network, and it may or may not spread, but it starts in a unilateral hemispheric network, whereas a generalized onset seizure starts in a bilateral hemispheric network. And so what we want is, or what the position paper is telling us is that when we use the term generalized, it needs to be about the onset and it needs to be about the pathophysiology. It's about the bilateral hemispheric network where the seizure is starting. If you see somebody or you get a history of somebody walks into the room and they see somebody on the ground and they've got both arms and legs symmetrically rhythmic jerking, previously people might have said that was generalized. But now we're taking that term away and only using it for the generalized onset seizures, so the bilateral hemispheric networks, and using the term bilateral to describe what you see from a semiological position. So if you see somebody or you get a history of somebody, they don't see the beginning of it, but they're seeing that there's both sides are jerking, then it would be bilateral clonic jerking, not generalized clonic jerking. So a focal onset seizure, which progresses to have both sides involved, is a focal to bilateral tonic-clonic seizure, and a generalized onset is a generalized tonic-clonic seizure. The next thing that came out in 2017 is the classification and terminology of the epilepsies. And this is the main figure from that paper, for that position paper. And the take-home message is that epilepsy diagnosis is there's three diagnostic steps or positions. So the first thing is we need to diagnose the seizure type, focal onset or generalized onset, and unknown if you're not sure. Then you need to try to think about what the epilepsy diagnosis is, so focal, generalized, and if the epilepsy has both focal and generalized seizures, it's a combined epilepsy. And if you're not sure, unknown. But ideally, we all want to get down to diagnosing a specific epilepsy syndrome. And the other take-home messages is it's important to consider the comorbidities of the child or the adult and the etiology of the epilepsy at all 3 stages in this diagnostic process. In 2021, there was a classification came out on neonatal seizures, which is not probably that relevant to you, so I won't talk about that in any detail. And then just a few months ago, or actually a few weeks ago, the 5 position papers came out, and these are the syndrome position papers. And so this has been a long time coming, and those are massive documents. They talk about a lot of different epilepsy syndromes, and they have new terminology associated with those, and they've tightened up the diagnostic criteria. So there's a lot been happening in terms of epilepsy from a point of view of the internationally. And then the other important thing that the ILAE has done is this epilepsydiagnosis.org, which is their flagship educational manual, which is online. It's a great place to go if you're wanting for a reference. So if you're wanting to know about a type of epilepsy, or you're wanting to know about a type of seizure, there's videos on there. So it's just a good thing to have up your sleeve as a resource. So that's what's happening globally. So what's been happening in New Zealand? So the New Zealand League Against Epilepsy has also been busy over the last 8 years. In 2017, we, with the Paediatric Neurology Clinical Network, which includes all the pediatric neurologists around the country, put together some epilepsy guidelines and pathways for children and young people. And these are based on the NICE guidelines, and they are aimed at pediatricians. And then in 2018, the New Zealand League Against Epilepsy introduced the pediatric epilepsy training courses to New Zealand. So these were originally developed in the UK, and they have been adopted by the ILAE as training for pediatricians mainly. But there are 3 courses, PET 1, 2, and 3. PET 1 is a 1-day course, and we would really highly recommend that all of you try to attend that at some stage because it's perfect for you if you have any children that you look after with epilepsy. And then PET 2 and PET 3 are mainly for the pediatricians, and they are both 2-day courses. In 2019, we made a concerted effort to make sure that the messaging that there was lots of information out there for families, and that the messaging was up to date and consistent. So we added a lot of new content into kids' health. So I would recommend that if you, that's the place to send people or families if they want more information about their child's epilepsy. There's videos on there about what an EEG is going to be like. There's videos about an MRI. There's videos, cartoons about what it's like to have epilepsy that the ILAE developed that we've got links to. So it's a really great resource. And then last year we accomplished the community health pathways, which is what we're going to talk about for the rest of the talk. So there's these 2 main documents that we've put together: the Epilepsy Guidelines and Pathways for Children and Young People, which is aimed predominantly at the pediatricians, and the Health Community Pathways, which are aimed predominantly at you. So, but there's a few things about the Epilepsy Guidelines that we thought, they're on the Starship website. You're more than welcome to go and look at them, of course. But everything that's relevant to you is in the community health pathways. There's a few things about them we thought would be important just to make sure you're aware of. So the epilepsy guidelines recommend that any child who has any event or a seizure needs to be assessed by a clinician with expertise in children, and that's you, or ED physicians as well as the pediatricians. But that if a children has an epileptic seizure or an event where it's unclear what that event is, they should be seen by a pediatrician with expertise in epilepsy within 2 weeks of an event. So who's a pediatrician with expertise in epilepsy? Well, what we're trying to do is make all the pediatricians expert in epilepsy by getting all of them to go to the PET courses. And we've had a really great pickup rate that most of the pediatricians in New Zealand who see kids with epilepsy have started going to these courses. And then children with the bad epilepsy, so developmental and epileptic encephalopathies, should be seen with a pediatrician, by a pediatrician with expertise in epilepsy urgently. So now let's focus on the community health pathways. So these are aimed at general practitioners. And this is the picture that so most of the screen dumps that I'm going to show you are from the Lower North Island pathways, because that's what I have access to. Presumably you all have access to things that look a little bit different. But there are 3 pathways that we published on there. So the first one is the new onset seizures in children. And this is a pathway for the first presentation of seizures or a new type of seizure in a child. And then there's the seizures with fever in children, and that's a pathway for children who are between 6 months and 6 years who present with a seizure during a febrile illness. And then the final pathway is epilepsy in children and young people, and that is specifically for kids under 16 who have an established diagnosis of epilepsy, the sort of things they're going to come to see you about. So we're going to move on to our cases, and in the cases we're going to come back to the health pathways and talk you through what you're going to find on there. So the first case is Julie, and she's 9 years of age, and her parents have turned up in your clinic, and they're concerned, and the teachers are concerned that Julie's been having episodes where she's blanking out over the last 3 months. Okay, so you hook on to those community health pathways and you hook on to the new onset seizures in children. And the first thing that's going to come up in the assessment is it's going to say, follow the seizures with fever in children pathway if the patient is aged between 6 months and 6 years and has a febrile illness. So she's not less than 6 years, and it's nothing to do with febrile illness, so you're in the right place. So that's as good. Then the next thing in the assessment is it talks about the things you need to get in the history. So the first in the history is about the actual event. So, and as you know, because you're all very used to these health pathways, everything that's blue either links you somewhere or it has a drop down and gives you lots more information. I'm not going to take you through all of those, but so it's important to know what were they doing before the seizure, what happened in the seizure, what happened after the seizure or during the seizure, and how did it finish and what happened afterwards. It's important to ask to see any video recordings, and if they don't have them, and they often don't in the first event, to really encourage them to do that if there's any more events. To ask about any other previous events, and particularly things that they might not recognize as seizures, so other types of staring spells or little jerks. To really make sure you find out about the development and what's been happening early on in their history, as well as around about the time where these events started. And then to find out about any family history of either sudden deaths or any cardiac arrhythmias or epilepsy. You need to do a targeted examination. And for this kid who's coming in with staring spells, that's pretty much doing a neurological assessment. But with the ones that are having bigger seizures, you're going to want to do a little bit more in the exam. It's important to make sure that you assess what their developmental level is. It looks consistent with what you're being told. And then for children who come with their first event where it's a collapse or a syncope, or it was associated with exercise, or there was any tonic or tonic-clonic component to it, it's important to get an ECG at that stage to try to make sure to rule out prolonged QT syndrome, or at least try to screen for it. But for this child who's only had staring spells, you don't need to do an ECG. And what you really just, all of that is all about trying to figure out whether, you think this is likely to be an epileptic or a non-epileptic event. So you take a history and you find out that initially this was happening once or twice in the afternoon when she was tired. Over the last few months, they've increased in frequency. She's now having them daily. The semiology, or what you see in the seizure, or what they're telling you is happening in the seizure, is she's staring blankly. She's unresponsive to voice for around 10 to 20 seconds. And she's had normal early development, but now there's a little bit of concern that she's having some difficulties at school. So you're trying to figure out if this is an epileptic seizure or not. And unfortunately, that history doesn't help you enough, because kids stare all the time, and just not responding to voice is not a very good way to differentiate between an epileptic seizure and just daydreaming. What's really important is you need to find out what happens if they tickle her, or if she's presented with something that she wants to do. So you go and get a little bit more history. So she is unresponsive to tickle. She's not having any other types of seizures. There's no significant past history, no family history, and her exam is normal. All right, so what do you do now? So what you do now, so clearly you're going to decided that you think this is probably more likely an epileptic seizure than not. So you're going to want to get this kid seen by a pediatrician, but how fast and how do you do it? So that depends on whether there's any features of concern. So in the pathway, we outline what those features of concern are. So if you're less than 2 years of age, if the seizures last longer than 5 minutes, if there's recurrent tonic-clonic or focal impaired awareness seizures within 24 hours, if they're having really frequent absences and myoclonic or focal aware seizures, which are impacting on their ability to function during the day, if they're unwell with features suggesting there might be a metabolic abnormality or some toxins or drugs or anoxia or acute cerebral pathology or anything else that's encephalopathic, if the ECG you did was abnormal, if they have any persistent new onset focal neurological signs, or if you're concerned about injury or them being unsafe, those are all the features of concern. So this girl does not have any features of concern. So you would ask for a non-acute pediatric assessment and mark that as urgent. If she did have features of concern, then you'd ring up the pediatrician and ask for an acute pediatric assessment and send them into ED. So that was great. So you sent her in, and she gets with your non-acute pediatric assessment, which is marked as urgent, and she's seen by a pediatrician with expertise in epilepsy 2 weeks later. Yay, tick, she gets all there within the epilepsy guidelines. And the pediatrician then agrees this is likely to be a type of seizure, so they organize an EEG, which is done within the next 2 weeks. And this is the event that is captured. It's hyperventilating.
She's fine. Yeah, she does. She's really doing well. Good girl. Now she's going in.
Stops hyperventilating.
How much is 2 by 2? Good girl. Keep easy.
And she's not responsive during that event. And she's got an EEG on her head. So we pick up that she's got beautiful 3 Hertz generalized spike and wave. So that was an absent seizure that was captured. Okay, so now the GP is going to, so they've made a they've got the EEG results, they've now made a diagnosis, and they're going to send you a letter back. And what we are encouraging the pediatricians to do in the PET courses is to put what we call describe, or what the PET is. It wasn't the British Pediatric Neurologists did this initially, is to put describe tables at the beginning of the letters. And so this is what a describe table looks like. And what it means is the D, describe, D is for description of the events, E is for epilepsy. So we want them to commit to, is it epilepsy or not? Commit to the type of seizures, commit to what they think their syndrome diagnosis is, make a statement about the likely cause, and then to write down any relevant impairments and behavioral and educational issues. So this is right up front, and everybody knows what everybody's talking about: the family, the GP, the pediatricians, the pediatric neurologists. And so for Julie, your first letter that you get from pediatrician comes back with a describe table, and it says, description of the events, arrestive activity. She stares, unresponsive to voice or touch for 5 to 20 seconds, many times a day. They think these are epileptic seizures. They've diagnosed that they are typical absence seizures, and they have made an epilepsy syndrome diagnosis of childhood absence epilepsy. The EEG shows generalized spike and wave. This is a type of genetic epilepsy, and she's got minor learning difficulties. So that's all great. It's very clear to you exactly what the pediatrician thinks is going on. They also then have, talk a little bit about the child, and at the end of the letter, they then have a plan. So they want to initiate ethosuximide, and they tell the family how to do that. They give the family a script, and they have an escalation plan for that drug if the kid continues to have seizures, and when they're going to see the child again. All good. So just a little bit quickly about what childhood absence epilepsy is. So this is the most common type of generalized epilepsy in children. Its onset's usually between 4 and 10, and they present with lots of typical absence seizures every day. They may have had previous febrile seizures, but they don't have any other types of seizures at onset. They've typically got normal development and a normal exam. This is a good epilepsy. It's usually drug responsive. The vast majority of kids will outgrow this, with 90% of them not having any absences by the time they get to 20, but they may have generalized tonic-clonic seizures, which begin in late adolescent, usually after they've no longer have absence seizures, and often are well off anti-seizure medications. You don't need to do any neuroimaging for this, but they will get neuroimaging if they are if they don't respond to medicines like that we would expect that they should. So this is an algorithm for management of childhood absence epilepsy. So this is what you might expect in the perfect or the best case scenario. So like Julie, present with staring spells, they get the EEG, capture the absence. They've got a diagnosis of childhood absence epilepsy, and the put on ethosuximide, which is, according to the epilepsy guidelines, is the drug of first choice. And then that drug will be modulated until ideally, hopefully, fairly quickly, the child will stop having absence seizures. And then at that stage, it depends on where you are and what the EEG resources are like. Some of the pediatricians may order repeat EEGs after the family aren't seeing them. Others will just work on base their management from then on what's being seen clinically. But if they're not having any absence, then the child will be maintained on therapy for 1 to 3 years, and then the drug will be weaned off. So that's a standard best case scenario. Okay, so but how you fit into that. So that's what's happening with the pediatrician and what's, 2 years on the drug. So where do you come into that? So as I've said, the pediatrician will have assessed and diagnosed the patient, but the ongoing medical care is between both you and the pediatrician. So we really want to emphasize and encourage you is to make sure that you see this child at least yearly in addition to the specialist. And that isn't just that they're coming in for something else and you happen to ask, that it's actually a dedicated appointment to review their epilepsy. So how do you actually do that? Because you're not like us, you can't book somebody in a year in advance, but of course you are the ones that are going to be giving the repeat scripts. All of their repeat scripts should be coming from you. They should only be getting scripts from their pediatrician when they're seeing their pediatrician. So how that might work would be, so in this case, so the anti-seizure medication would be initiated by the pediatrician, and they'd give them a 3-month script. And then usually they would get the kid to come back around about that time, because they're going to want to know how if they've actually stopped the seizures. And if they have, they'll give them another 3-month script, and they'll say they're going to see them in 9 months. And so then the child's going to come back and need a script at 6 months. And at that stage, you should get them in and review them. The 9-month script, you could just give them, and then they're going to go back and see the pediatrician at 12 months. They'll get another 3 months. They'll then decide if things are all going well, then maybe see them in a year. And then at 15 months, you could give a child another script. But at 18 months, you get that child back in and have another review of their epilepsy. So therefore, you've now seen them twice, a year apart. And then they'll go back to their pediatrician. And if everything's great, like it was in that algorithm, they'll probably have their anti-seizure medications weaned, and that'll be their epilepsy done and dusted, hopefully, touch wood. So what are you supposed to do in these appointments that where you're seeing them just for their epilepsy? So in the guidelines or in the pathways, we've given you a list of what are the things that it's important for you to consider and to ask about. So ask about any epileptic seizures, check for side effect of anti-seizure medications, make sure that they know what to do if they have a seizure, and that they are actually taking their medication, and that that they have a written management plan, which presumably will most likely be the pediatrician's letter. Make sure that they know what to do if they miss the doses or that they're sick. And then also it's important for you to inquire about comorbidities, particularly mood and behavior, addressing any psychosocial problems, reviewing their growth, and asking specifically about how their development is progressing. If they need any additional support, you can refer them to Epilepsy New Zealand or to the Kids Health website, where there's lots of more information. So you'll get a feel for how their knowledge is, and if they need more information. And then it's also really important to make sure you ask about whether the child's menstruating, because it's everybody's job, the GP, the pediatrician, the pediatric neurologist, the pharmacist, to make sure that these individuals understand the risks of epilepsy and the anti-seizure medication in pregnancy. And we need to make sure that they're aware of the situation. We need to recommend adequate contraception, which if they're sexually active needs to be 2 methods. And that talks about that in that drop down. And if they're pregnant or planning a pregnancy, hopefully not at a 9-year-old here, but you need to give them some folic acid. What you don't need to do is any routine blood tests. So there was a sort of, historically that was something that got done, but we realized that is not necessary. And so you only need to should only think about ordering blood tests in specific indications. And that would be for phenytoin. If they're on phenytoin, that can be a tricky drug can become toxic very quickly. So those kids tend to get levels taken to make sure that they're therapeutic. Or if the child presents with something that may be due to the drugs. For example, sodium valproate can decrease platelets, which can result in bruising. You don't need to measure their platelets to see if they're low. You only need to worry about that if they come in with bruising. So if they're coming in and you notice they've got bruises, or family says they're bruising more, then you would have a much lower threshold for ordering blood tests to check on that than if they weren't on sodium valproate. And then also, if you're concerned that maybe they're not actually compliant, you might check a level that way to see if they're actually getting anything, if their drug's getting into them before you start ramping it up. Okay, so now we're back to Julie. So she's had her 3 months ped review. So, and this is the describe you get back in the 3-month letter. So same thing about the description of the events, and she's having typical absent seizures, and they're right that she's seizure free since the anti-seizure medication was started. So that's great. The ethosuxamide's working. And she's on 250 milligrams or 20 milligrams per kilo, and she weighed 25 kilos at that appointment. All good. Okay, and then they give you a plan of what to do if she has any more seizures, and they're going to see her in 3 months. So you get her to come back in at 6 months, as we've recommended, and you go over the things that it says to do in the pathway. So you find out that after that she saw the pediatrician, she had some absent seizures. That was about 2 months ago. So the parents increased the anti-seizure medication as it was directed in the pediatric letter, and now she's on 500 milligrams twice a day, and she's been on that for about a month. She's gained some weight. She's now 27 kilos, so the dose is 37 milligrams per kilo, and she's not menstruating yet, and there's no problems about side effects. But they are still fairly confident that she's still having absent seizures, and the parents and the teachers are noticing those several times a week. And these are exactly the same events that she had prior to when she first presented. So there's no concern that she is having absences. So back to the pathway. So patients experience a significant increase in seizure frequency. Well, I mean, the pediatrician thinks that she's seizure free. That's what they're aiming for. So any seizures is an increase in seizure frequency. So what does it say to do? So the first thing is to check whether they have been able to access and they're actually taking their anti-seizure medication as prescribed, and compliance. So you do that, you find out, and she's very good, and there's no doubt she's getting it twice a day, just like she's supposed to. And then the next thing it tells you to do is go back and check the pediatric letter for advice about dose titration in this circumstance. So you go back to the letter that you last got, and it says what to do, and the family have actually followed that, but they've only gone up to here. And so the other thing is that was 25 kilos, she's now 27 kilos. And so what that means is actually you could even go up another dose up to 750 and 900 if you wanted to. So what you're going to do then is tell the family to follow on that letter. So to go to 500 and 750 for 2 weeks. If she's still having seizures, they can go to 750 in 2 weeks. So really encourage them and enable them to do what the letter has said. And you can tell them they can go a little bit higher because she now weighs a little bit more. If you get to the end of that escalation plan, or there is no escalation plan in the note, that's when you need to send back for a non-acute pediatric assessment to get them seen earlier. But you don't need to do that until you run out of whatever the plan is in the letter. So she's got good compliance. They follow the plan in the pediatric letter. And then at that stage, you should tell them if they're still having seizures after they get to the top of that plan, they should let you know and come back. And the next time they need a script, you should get them back in again, just to check that they're not having absences anymore. And if they are still having them, you should let the pediatrician know so they can be seen quicker. So 9 months. So what happens with Julie over the next couple of years is she comes back in, you review her after 3 months for that next script, and great, she's up to 500 and 750. She's having no seizures and not concerned about the side effects. All is good. 12 months, she goes to see the peds. There's no seizures, no concern. 15 months, you give them another script. 18 months, you give them another script. 21 months, you get her back in and ask again about her seizures and her meds. 24 months, review by peds. And she's now been seizure-free for 18 months because she didn't actually stop right away. So 27 months, you can prescribe another script. She goes back to the pediatrician. She's been seizure-free for 24 months and her anti-seizure medications are weaned. So you've both, the pediatrician and the general practitioner have both worked really well together to help manage that child. Okay, so now I'm going to give you a bit of a break from me, and Sue is going to talk about the next case. So Sue.
Hello. Well, my case is Sean, and he's 12 years old. And Lynette is going to handle the progression of the slides. Thank you. So Sean presents with dizzy episodes. They last about 20 seconds, and he's actually had them for a few years. He has been seen by a pediatrician, and they're thought to be vasovagal episodes. So the next month, he actually has a more significant event. So this time the dizziness is followed by an alteration in his awareness. So he's fidgeting with his hands, he's making lip smacking movements, and he's walking on the spot for about 30 seconds. And then he falls to the ground and has bilateral symmetric clonic movements of his body and limbs. So he's had a focal to bilateral seizure. So the family called the ambulance and he's taken to the emergency department and admitted to the hospital under the pediatricians. So at his discharge, the describe in the letter is that he's had episodes where his heart pounds, he's scared and dizzy. Then he's had an episode of decreased awareness, fidgeting, lip smacking, walking on the spot, followed by bilateral limb jerking. So that's a description of his event. His epilepsy started at age 10 years. So he has both several different seizure types. He has focal aware seizures. Those are his episodes of feeling his heart is pounding, he's scared and dizzy. He has focal impaired awareness seizures. So these are the episodes where he is unaware of his surroundings and has sort of some automatic behaviors. And he has, thirdly, focal to bilateral tonic-clonic seizure. His syndrome is temporal lobe epilepsy, because in addition to having the typical symptoms of a temporal lobe seizure, his EEG shows some abnormalities in the right temporal area. And in fact, the MRI shows a structural lesion, which is one of the commonest structural lesions we see presenting in children and young adults, which is a cortical dysplasia, and it's in the right medial temporal area. There's no behavioural or educational issues in this young man, and he is started on carbamazepine, and the dose is gradually increased. So he reaches the maximum dose of 1,800 milligrams a day, which is approximately 37 milligrams per kilogram per day. He has fewer seizures, but he's still having focal aware and focal impaired awareness seizures as often as weekly, which is too much for a young person to function normally. In addition, he's tired, unsteady on his feet, and has some blurring of his vision, suggesting that this may be too much medication for him. So the plan from the paediatrician is to decrease his carbamazepine and introduce a new drug, which in this case is lamotrigine. So 1 month later, you see him urgently because he's developed a rash. And the family have been told to contact their GP immediately if a rash occurs. Thank you. So the plan is then to gradually start decreasing the carbamazepine and beginning a dose of lamotrigine. So he's really only on a small dose of lamotrigine, but it's been 1 month on lamotrigine. So when you look at the rash, it's a maculopapular rash. It involves his arms. It's gradually increasing in the area of involvement. Plus he has a sore throat, and other families have had a viral syndrome as well. So the serious concern in this case is that the rash has occurred after starting anti-seizure medication, and that the recommendation is to seek advice from paediatricians. And I think you've forwarded the slide too quickly. Can you go back? Okay. So one of the serious concerns to seek medical advice is the appearance of a rash. So if a rash occurs after starting seizure medication, it usually begins with between 2 and 8 weeks of starting the drug or increasing the dose. And the anti-seizure medications most commonly that associated with a rash are carbamazepine, phenytoin, lamotrigine, and phenobarbital. So the rash is typically maculopapular, and it can be associated with lymphadenopathy and hepatosplenomegaly in severe cases. It's very difficult to distinguish it from a viral rash. And if the medication is continued, it can lead to a severe life-threatening illness. So it needs to be taken seriously. So you contact the local paediatric service, and the registrar consults the consultant in this case, and the recommendation comes back to you to discontinue the lamotrigine immediately and to continue the carbamazepine, given that the carbamazepine is outside that 2 to 8 week period when a rash is likely to occur. So because carbamazepine at the current dose was not effective, you are instructed to begin a third drug, levetiracetam, and given instructions as to how to escalate the dose. And the plan then is to review the patient in 2 weeks or sooner if the rash does not resolve. So the lesson in that is that you, as a GP, the rashes are going to come to you. It's an important differential diagnosis between a viral and a drug rash. If you're uncertain, the most important thing is to discontinue the drug that either was introduced or the dose increased within that 2 to 8 week period.
Okay, so now we're going to the last case, and this is Mary. Back to me. Okay, so Mary's got a little bit of a past history that I'm going to tell you about first. So she presented at 14 months with a cluster of focal impaired awareness seizures. She's had 14 seizures over a 3-day period. She had normal development and exam and no family history, and she was diagnosed at that stage with focal epilepsy. She carried on having seizures so that by the time she was 3, she was having clusters every 3 months, and these clusters were lasting like a week. And that was resulting in her losing skills, developmental skills within the cluster. And then it took about a week for her to get back to normal. But in between these clusters, the development was great. She was counting to 10, riding a tricycle, all good things for a 3-year-old. But by 4 years, she's now failed 6 different anti-seizure medications. Her clusters are continuing, and she's not returning to normal after the cluster. And this is a figure to show you how many seizures she was having. So the clusters per year are on this axis, and this is her year of age. And so you can see she was having a lot of clusters, so almost, almost up to one a month at that stage. And then at 6, she was put onto levetiracetam, and she stopped. So things went well. So she's now 12, and you've been seeing her managing her with her pediatrician and her pediatric neurologist for the last 10 years or 11 years. And she's just seen the pediatrician, and the letter comes back with the describe, and it says that her previous seizures were screams and looks fearful, arms lift, and she's unresponsive for 2 minutes. So that's a focal impaired awareness seizure. That then sometimes that progresses to bilateral stiffening of the limbs and rhythmic jerking of the body and limbs for a minute. And that's a focal to bilateral tonic-clonic seizure. That she has epilepsy from 1, but she's had no seizures for 6 years. And her diagnosis is of a developmental and epileptic encephalopathy. So remember, this is the severe epilepsies where the seizures impact negatively on the development. And specifically, she has what's the syndrome name known as PCDH19 clustering epilepsy. This is genetic, and she has the de novo pathogenic variant in PCDH19. She's ended up with mild intellectual disability, and she is now on levetiracetam 40 milligrams per kilo. So just quickly, a little bit about PCDH19 clustering epilepsy. So this is a developmental and epileptic encephalopathy, presents under 3 years with clusters of focal impaired awareness and focal to bilateral tonic-clonic, so just exactly like Mary. And they usually end up with some degree of intellectual disability plus or minus autism. Unfortunately, when they're in their late teens, early adulthood, they often can develop psychosis. And it's a really interesting X-linked disease because only girls get it. And PCDH19 is a gene that codes for podocoherin 19 protein, which has a role in cell-to-cell adhesion of the cortical brain cells. So she's 12 years old, and all of a sudden the family, so she saw the pediatrician a couple of months ago, and now the family have made an acute appointment to see you because her behavior has deteriorated over the last 2 months. She's tired, she's resistant to instructions, she's not going to school, she's aggressive with other children at times, and she's really hard to please. And the family have been thinking about what could possibly be causing it. And they've decided it's the levetiracetam, and they come armed with the New Zealand formulary medication information sheet on levetiracetam, and they've highlighted for you the possible side effects of levetiracetam, which are behavioral change, drowsiness, seems less alert, changes in mood and aggression. So they think it's this drug, doctor, and we think maybe we should do something about that. So you go back to your epilepsy in children and young people pathway, you go to the managing serious concerns, and now we're talking about behavioral concerns or drowsiness. So what it says when you open that up is consider whether the change in behavior is associated with an alteration in anti-seizure medication or dose in recent months. Okay, so you review the history. She's definitely not having any more seizures. She hasn't had any regression in her development, and there's been no changes in the levetiracetam dose for 3 years. And in fact, her milligram per kilo dose is much less than it used to be. She was 60 milligrams per kilo, but because she's been growing, she's now only 40 milligrams. So it's actually decreasing effectively. So that means it's highly unlikely that her difficulties that she's come to you with are related to the epilepsy or to her levetiracetam. So you got to think, okay, what else is going on? And so indeed, this is what the pathway says, investigate other causes. And now I've just drawn this diagram because I think it's just a helpful thing to think about all of the things that a child with epilepsy might impact, what things might impact on their behavior, because there's lots of different things. So the red arrows are negative impacts and the green arrows are positive impacts. So the underlying disorder, PCH19, on its own, regardless of seizures, can result in intellectual disability. And we all know that kids with intellectual disability, especially when they start getting older and getting more different from their peers, can end up with has an increased risk of behavioral problems. This gene causes a developmental and epileptic encephalopathy, so the seizures can add to the negative impact on development. And also the seizures themselves can negatively impact and result in abnormal behavior. They're also on anti-seizure medication. And of course, that's got positive green arrows, because if it's decreasing the seizures and it's decreasing the effect of the seizures on development, then that's going to be a positive thing on behavior. But in itself, it can be a negative impact, and that as the family have shown you, there is known negative side effects of this drug at times. But of course, it can also be having a positive effect. And you've probably all seen kids who've come off of an anti-seizure medication and their behavior is deteriorated, and that's because there can be some mood stabilizing effect of the drugs. But if forgetting about all of this is what's the major effect on kids' behavior. And it's really natural for family members to blame the seizures and the drugs they're on for everything, all the problems they have. But most of you really got to think about what else is going on here. So you take more of a history, and she's not eating very well, and she's not gained much weight in the last 2 months. She's not sleeping well. She's not smiling and interacting as well. 2 months ago, the taxi driver that she loved and had driven her to school for 7 years died. And they were having trouble getting her into the taxi because she doesn't like the new taxi driver to go to school. So you're thinking, well, maybe she's depressed. And she's got some reactive depression, or or she's got something that really is impacting on her mood. So at that stage, if there's the guidelines would say, if there's considerable psychological behavioral issues or possible attention deficit, request a non-acute child and young person's mental health assessment. So it's better to go that way rather than to refer them to the pediatrician. Okay, so that's our last case. And so our aim has been to try to help us all work together to improve the quality of care for children with epilepsy. We think it's really important that there's good communication between the pediatricians and the general practitioners, that you guys really understand each child's individual epilepsy and their comorbidities, and you're engaged in that management, and that the families see you as an active role. And they will only do that if you actually have them coming in to see you for their epilepsy. What we want to try to avoid is that the family think that you're just a way to get to the pediatrician, because of course you're not. There's lots of things that you can manage yourself, and the more you do that, the more faith the families will have as well in going to you. And so hopefully there's lots of resources. There's the pathways you can go to, and hopefully these pathways are going to help you feel empowered to deal with things when they come to you. There's the guidelines, there's the PET courses. We would love you to come to PET 1. And then of course you've got epilepsydiagnosis.org. So thank you very much for listening. It was a long time to listen. And so now we've got about 20 minutes, I think, of where we can answer all of your questions.
Wonderful. Thank you, Lynette and Sue. That was a fantastic talk. We do have a number of questions, so we'll start with those. I wonder, please, just clarifying on the health pathways, we've got a comment that the pathways you've mentioned aren't on the Southern health pathways. Are they available across the nation?
They are, so they came out at the end of last year, and as far as we're aware, all the DHBs are adopting them. So I'm surprised that they're not there. So we'll look into that. Because I know they're definitely on the lower half of the North Island. They're definitely up in Auckland. There was one of the DHBs was a little concerned about one of the pathways, but we sort of talked through that. So they should be. So if you can't see them, can you please let us know? Because they are national pathways that were developed, and they should be available to all of you.
Fantastic. And it may be worth actually talking to your local GP liaison at your DHB to see what's happening there. So that's great. Thank you.
Tell them to go and make them available.
Yeah, that's wonderful. Thank you. There was a comment about from sleep. So in your initial definitions, you said from sleep. Can you just explain what exactly you meant there?
So what I meant is that the kid was asleep and the seizure happened while they were asleep. And so that's often what happens at night, and you don't really know about the onset. So you can't tell if somebody has an event where the family hears a noise or they hear a thud and they go into the room and they can see the child is jerking bilaterally. You can only say it's a tonic-clonic seizure. You don't know if it's generalized onset or focal onset. So that's all I meant. It's just sort of, it's coming, the seizure starting from sleep. And in some of the syndromes, you're more likely to have that.
Great. And just some definitions. So TCA, can you just explain TCA?
TCS, tonic-clonic seizure. I think it's probably, I don't remember having a TCA anywhere.
No, I saw lots of TCS, but okay.
TCS, sorry, it was in the first slide, but so tonic-clonic seizure.
Fantastic. So just thinking now about the absence seizures, the learning difficulties that you mentioned, is this because of disturbed schooling or an underlying brain injury?
Do you want to answer that, Sue?
Well, there's two ways in which a child with typical absence epilepsy might have impacts on their school performance. One is that their attacks are so frequent, they're missing what's going on in the classroom. So in that case, the teacher may need to repeat instructions to make sure that they're heard. But those children who have such frequent attacks really need to be treated. But we also know that children with typical absence epilepsy do have more learning problems going forward into teenage and adult years, that there are cognitive and social risks of having even that most benign epilepsy syndrome.
Great, thank you for clarifying that. And you mentioned febrile seizures, 10% will do they predispose to absence?
No, the childhood absence epilepsy is a type of genetic epilepsy. So you're inheriting genes, and there's very few monogenic causes that we know of. So you're having a polygenic risk. So you're probably inheriting, a sort of a portfolio of genes which are increasing your risk of having childhood absence epilepsy. Febrile seizures is also a genetic disorder. And so some of the risk factors, the genetic polygenic risk is equal in both. So people who have childhood absence epilepsy, some of them will have febrile seizures as well. But the febrile seizures don't cause the childhood absence epilepsy. It's just that 10% of kids that have childhood absence epilepsy will previously have had febrile seizure. And it's probably just due to the shared genetic etiology of both of those disorders.
Fantastic, that's great. Thank you for clarifying that. And just a question about absence seizures and ADHD. Is there a correlation there?
You want to do that, Sue?
Not that I'm aware of.
No, I was just going to say one of the things that's sort of interesting, I think, is so there was a huge study on childhood absence epilepsy. I think it's still the biggest pediatric drug trial in any disorders that happened mainly in the States. I think it was 700 kids or something, new onset, by Glauser. It was a big paper, and they randomized the kids to of new onset absences to ethosuximide, sodium valproate, and lamotrigine. And the primary endpoint was stopping seizures. And ethosuximide and valproate were equally as effective. And the secondary endpoint was assessments of cognitive assessments, and mostly attention. And so ethosuximide, they did much better on those tests. So there is a little bit, the drugs that we're using, so that's one of the reasons why ethosuximide is the drug of choice, is because it's less likely to have any negative impact on attention. So sodium, whereas sodium valproate can do. Lamotrigine is by far the best of the three of the drugs in terms of impact on attention, but it wasn't quite as effective at stopping the absence seizures.
Right. You mentioned stopping medications once they've been seizure-free for 24 months. What's the rationale behind that?
Statistics.
Okay, so what do we expect after 24 months? Do we expect the seizures to have gone away and not come back?
They're more likely at that point to have resolved. And really it depends on the epilepsy syndrome as to where the likelihood. So for typical absence epilepsy, we know after age 9 or 10 years that they're less likely to continue having absence seizures. So if a child starts medication at age 6 or 7, by 9 or 10, they're likely to have grown out of the disorder. So it's really a combination of factors. So the 24 months is a guideline. It is not necessarily the way that what your recommendation would be. It depends on the syndrome and the child's age.
Yeah, yeah, I totally agree. The thing about, so childhood absence epilepsy is a self-limit, what we call a self-limiting epilepsy. And so what that means is that even if you treat these kids, if you don't treat these kids, they'll outgrow it. It's just that they're going to have a lot of seizures over a long period of time. But most of them will actually, by the time they're late teens, will no longer have absence seizures. But the whole 24 months, it's all about 50%. If you got a 50, if we think you've got over a 50% chance of having future seizures, we tend to recommend medication. If we think you've got an under 50% chance of having future seizures, we tend to stop medications. And so at the 2-year mark, you've got at least a 60% chance, particularly with childhood absence epilepsy, that you're not going to have any more seizures. So hence that's why the 2 years, but it's over 50% also at 1 year. So some people actually do it a little bit less, but we don't have great research and evidence for a lot of the when do we stop. It is a lot, it's anecdotal, and we just sort of make our, the best guesses. But with the self-limited epilepsy syndromes, we know they're going to, outgrow them. So we want to give them an opportunity to come off their drugs, so they're not on something that they don't need.
So then if the seizures recur,
then you would just put them back on. So not all of them. So like I think I said in that slide, 60% of them will have stopped having seizures within 2 years, but that means 40% of them are going to carry on. When you wean them off, they're going to have more seizures. So you just put them back on again, but 90% of them are going to be off, are not going to need meds by the time they're 20. So in general, you just sort of put them back on for a while, for another year or 2 years, and then try them off again.
Fantastic. That's great. Thank you for clarifying that. You mentioned cortical dysplasia in temporal lobe epilepsy. I wonder if you can tell us what about that. Why do these children have cortical dysplasia?
Well, with modern imaging techniques, with MRI, we've become aware that many people with focal epilepsies have subtle changes on the MRI that requires a high quality MRI done with an epilepsy protocol, that the areas where the cortical layers are not organized in a normal fashion. So there are different types of focal cortical dysplasia, and some are quite localized and some involve large areas of the brain. Lynette knows more about the genetics of this than I do, but there are local somatic changes in DNA in the areas of dysplasia. And so some of them are genetic, and others are just local mutations in that area of the brain. Am I correct, Lynette?
Yeah, so there's a lot of research at the moment looking at trying to figure out what the genetics of the cortical dysplasias are and of the cortical malformations in general. So there are some genes which predispose people to having cortical malformations, and those are so that's basically in all of their cells, but they're more likely to end up with a cortical malformation. And then there are some which are just in the actual malformation themselves. So it's not something that you've inherited. It's a mosaic mutation just in those cells in the brain. And so there's a lot of research at the moment, particularly in the kids that have surgery, looking to see what those mutations are within. And we know some of the genes, but we don't know them all. But it's most likely genetic. Great. Some malformations are due to insults in utero, so like polymicrogyria and things. But the majority of them are probably genetic.
Okay. Yeah. So CMV infection is one of the major causes of cortical malformations. We're interested in areas of cortical dysplasia because in many patients with focal epilepsy that doesn't respond to anti-seizure medications, we know that we can remove the area surgically and get a good result in terms of curing the epilepsy. But that really is only for cortical malformations that are in what we call non-eloquent areas of the brain. So it's important for you to know that some epilepsies can be cured with surgery.
Perfect. I wonder if we can just go back to the question about medications and absence seizures. So we've stopped our medications, the seizures come back. Do we start on the previous dose or do we start slowly and titrate up? How do we manage that? Good question. Okay, so what we do is we'll go back to our health pathways, and this would now be seen as a new sort of, if they've been seizure free, they need to go back to the pediatrician I wouldn't recommend that the general practitioner reinitiate, because you never know, the pediatrician, 2 years later, Sue? No, surely you're going to want an EEG or something. I mean, you need to remanage, because I think it's really important to think again, are they actually the same seizures? You have to go through it's the whole same process again. But I guess what Sue's thinking is, if they've just come, usually most people who are going to relapse in the wean or within the first little while. So if it is that, then yes, you could just go back on, and you can just follow exactly what it says in the New Zealand formulary in terms of initiating those drugs, and that's fine. Are you shaking your head now? Am I getting a plus?
Yes, I agree. I think that many, it might be so simple that the GP can simply restart or go back up to the full dose when seizures recur. Usually they do happen during the wean of the medication, so it's quite straightforward, really.
Yeah, that's true. I was thinking of the scenario where they've been seizure free for a while, but yeah, that doesn't usually happen.
Well, you do need to think about whether they are the same seizures or
because sometimes with absence, I think what happens is that because they can be quite subtle, right? And as you get older, the semiology can change. So you can have a child who presents with really typical absence seizures at 6, where they're busy eating their cereal and they stop and they're staring, and then they carry on eating. These really brief interruptions in their activity, and they're really out of it. But as you get older, you're more likely to be able to have some level of awareness in your absence seizure. So it can become a little bit tricky later on to be sure, and so it's always important to think again. You don't want to be treating something that is not, just because they had absence seizures previously. You got to be really sure what you're seeing is absences.
I just want to mention that for young people who've had a history of epilepsy, that when they reach their mid to late teens and are faced with leaving school, a protective environment, getting a job, making new friends, that's often overwhelming to the point that they do develop non-epileptic seizures modeled on what their epilepsy has been as a younger child. So it's a very vulnerable age, the mid to late teens, for non-epileptic events. So that's why you've always got to rethink, are these the same events as occurred in childhood, or is this something new? It has to be rethought.
Yeah,
So,
and that's a really important message to always think. And one of the reasons why the describe table is so important is every time I come in, every time a patient comes into me, I go over those events. Is this still what's happening? Are we all on the same page for what we're treating or what we're managing here? And so it's always, because sometimes you just say, oh, how are your seizures going? And they go, oh, we're having these seizures, blah, blah, blah. And you can get at risk that you actually realize, oh, they're talking about something completely different. I don't know what then. I don't think those are seizures. Yes, it's really important to every time it's like, okay, this is what you said last time. Is that what's happening now? Or is it different?
they don't like you for that. So they said, I've told you what the seizures look like, and you keep asking every time I see you.
It's important.
You're just a nuisance, Lynette.
I know, and I say, and get it on a video and bring it back. I'd like to see them.
We're coming towards the end, but I've got a couple of questions that I'd like to get answers on. So if we have a patient who's got increasing seizure frequency at the maximum dose of the provided plan, what do we do then, and how urgently do we need to get help?
Do you want to do that one, Sue?
Well, it depends on the seizure, obviously. If somebody's having major seizures where they've got impaired awareness, they're confused, disoriented, they're not safe, or they have focal to bilateral seizures, then that's quite urgent, and they should really be seen in the emergency department and perhaps admitted for urgent management. It really depends on what's happening as to how urgent it is. If they're minor seizures, the person is having focal seizures but maintaining awareness, then they just need an urgent referral to an outpatient appointment.
It's almost like you're going back into the beginning of that new onset seizure pathway. So we didn't open up that box, but one of the box for breakthrough, increase in frequent seizures and breakthrough seizures has a list of you're back to, because ideally if they're having lots of seizures, as Sue says, they need to be seen by somebody either now or at least within 2 weeks, or the other option you have, I think, is to contact the pediatrician. Send them a direct note to get an immediate plan while maybe they're waiting for their next appointment. But you can't let kids have a big increase in frequency of seizures. And it's always good, to let the pediatrician know what's happening as well. So if you're going up through that plan and you're getting close to the end, if you let them know, they might give you a little more of a plan, or they may actually book them to come to see them at around about when that plan will be ended, so that they actually can help you if that plan doesn't work.
I just want to make a comment about people whose seizure control deteriorates or they start having more frequent seizures. The most important thing is to determine if they're actually taking their medication and what the barriers are. They can't afford it. They don't have transportation to the pharmacy. They're having side effects and they don't like it. So I have to say, with adult neurology services, they're so stretched in terms of resource that if a patient is non-compliant with medication, they don't want to see them. And so it really is in your ballpark to make sure that your patients, when they're not taking the medication or they keep stopping it, that there's a reason and you need to find out what that reason is and try to resolve it. So a really important message about non-compliance. There's always a reason behind it.
Yeah, and if the reason is the side effects of the drug, then, because we've all seen, when we've done mortality reviews of adolescents that end up with SUDEP, these poor kids that just stop taking their drug because they don't like the side effects, and they keep turning up to AED or, and being told to go back on the same drug, when there's lots of drugs they could try, so it is really important to advocate for your people with the pediatrician and say, look, this is really, they're not tolerating this, the blah, blah, blah as well. But compliance and looking at side effects and thinking about, whether something else could be, make it easier for them. It's important.
Just before we end tonight, I'd like to ask a question about CBD oil because it's come up a number of times in the Q&A. Parents are often looking for alternatives to drugs, and CBD is very in vogue. So can you comment, please, on if there is a role for CBD, and if there is, how do we go about using it?
Do you want to handle that, or do you want me to?
Well, CBD is another anti-seizure medication. We know quite a lot about it. We know specifically syndromes where it's very effective, and it's been shown to be effective. There are epilepsies where we don't have the evidence that it's effective. And I think we're all working very hard at the moment to get it funded for specific conditions. Lynette, do you have any progress report on that?
No.
And it's working on that?
Yeah, we're working on that. So I think, the first thing, of course, is, as Sue said, CBD is a drug. And so the families need to realize CBD is a drug. It's not a non-drug. It's just and it's not a miracle drug. It is, it's another anti-seizure medication. It has side effects like all the other anti-seizure medications. Some people don't tolerate it. And in some people, in some types of epilepsy, it works very well. And we have fantastic randomized controlled trials to show that CBD is effective in Dravet syndrome and in Lennox-Gastaut syndrome. Those are two of the developmental and epileptic encephalopathies. And there's no doubt about that. It's a good anti-seizure medication for those two syndromes. We also know that there's been trials of CBD in focal epilepsies, and it wasn't effective. We also know that so CBD, of course, is in preclinical models is shown to be anti-seizure, and in the big drug trials for Dravet and Lennox-Gastaut, it seems to work. The other thing, I guess, to mention is that THC is shown to be pro-convulsive. So, when they're looking at just marijuana, THC is probably not good for seizures. But I think the other thing that you need to make sure the families all understand and appreciate is that it needs to be pure CBD. A lot of the stuff that they can import or they can get, they don't, they don't know what's in it. They don't know what's not in it. They don't know how consistent it is. If it's got THC in it, it might increase their kids' seizure. If there's other things in it, it might increase their seizures. And the other thing I think to remember for them to remember is, even in the syndromes where we really know that it works really well, the doses that they're using are quite high. And the doses that when they're getting the stuff that they're importing from Netherlands or something, the doses that they're being told to use are incredibly small. They're homeopathic doses. They're not effective, and they can afford, and it's partly being recommended that way because that's all people can afford. If you actually had to take the dose that would be effective, it's hundreds, well, what is it, $30,000, $40,000, $50,000 a year. So,
where are we with getting it funded by Pharmac?
So we've put in for Dravet syndrome. So Epidiolex is the only pharmaceutical grade product that is not available in New Zealand, but that is available internationally. And so we've put in a physician initiated application to Pharmac for them to fund for Dravet syndrome. If that's approved, then we'll try and get Lennox-Gastaut syndrome approved. But Epidiolex won't be funded for the epilepsy syndromes where there's no evidence that it works. And there has been a big Wellington, New Zealand, a lot of New Zealand people were involved in the randomized control trial in focal epilepsy of a pharmaceutical grade CBD product, and it wasn't effective.
Mm.
So the trial was negative. So it's not just that that we didn't have information. They did the trial and it didn't work.
Mm. Great. Well, thank you for clarifying that. I think that will have answered a number of our questions in the chat. So I'd like to thank you both for your time this evening. It's been an excellent webinar, and I certainly have learned an awful lot. So thank you everyone for joining us tonight, and enjoy the rest of your evening. Kia ora and good night.